I give a special thanks to Dr. Sir Kailash sir to giving this wonderful opportunity and knowledge sharing sessions on role of Villandol fluticasone in OAD management. As you know, sir, Villandol is a newer molecule coming in OAD picture. I will like to give a small introduction about Dr. Kailash sir. Dr. Kailash sir has completed MD, DTCD, MACP. He is a senior physician and chest consultant with special interest in asthma and allergy. Sarah is mainly seeing that asthma patients, allergy patients, and TB patients. Sarah having huge experience, more than 30 years, and Sarah is a medical director of asthma studio at Velachery. Sarah has been is teaching faculty in Madras Medical College and Kilpauk Medical College for both the undergraduate and postgraduate courses. Sarah has obtained fellowships also. Sarah is also having memberships for various reputed medical bodies. Sarah has conducted numerous medical conference, seminars, workshop, etc. Sarah, one of the main doctors and one of the top KOL and one of the top leading pulmonologists in Chennai. Currently, Sir is a president of IMA Chennai Metro and secretary of Independent Medical Practitioner Associations of India. Also, Sir is as a medical director of Venkataeswara Hospital in Chennai. Sarah's special interest in talking to the medical profession on chest topics and especially airway disorders. I hand over the sessions to Dr. Kailash sir. It's a very pleasure, sir, to give
Yeah.
introduction about sir. Thank you, sir.
Thank you.
Sir,
Thank you very much, Vignesh. And I think we'll start off with the program. Uh, in fact, we have last 15 to 20 years, there isn't much of a difference in the management for COPD or asthma. Not many new drugs have come. Therapy, we were using formoterol, budesonide, some glycopyrene, of course, came recently for COPD. But for asthma, not much of drugs have come. But off late, Cipla has brought out a wonderful drug about which we're going to talk today. What is the importance of the drug? How this drug can really revolutionize treatment for asthma. This is what I'm going to talk to you in the next 1 hour. Okay. Of course, before we go, we should know something about COPD. COPD is a disorder, chronic pulmonary obstructive disease, is a common preventable. In fact, you'll be surprised to know COPD is the third killer. Currently, is the third killer in the world. COPD, when I finished MBBS, it was about 20th or 30th killer. But in the last 30 to 40 years, it has really jumped so many things and come to the third killer. And we expect COPD to overtake. The first killer in the world is myocardial infarction. The second is stroke. And third, of course, it is going to overtake stroke shortly. And maybe after about another 5, if the pollution really increases, then it will become the number 1 killer. But they say by 2030 or 40, COPD will be the first killer. It is characterized by persistent respiratory symptoms. The word persistent is very important. In asthma, you have intermittent respiratory system, whereas in COPD is persistent. In fact, if a COPD case comes to us, I am always worried because this person is not going to get any relief much. Till this drug had come, we not much of. You would like to refer it to somebody or some other pulmonologist. But now, after this drug has come, we are really happy. There is airflow limitation due to airway or alveolar abnormalities, which I'll tell you. It is either emphysema or chronic bronchitis, usually caused by significant exposure to noxious particles or gases. The biggest problem is the pollution. The pollution is measured in a unit called ppm. Normally, our lungs can take up about 60 ppm. That's the maximum we can take, about 40 to 50, not even 60, 40 to 50. But the amount of pollution in Chennai itself is about 300 to 400 people. Many places it is 300 to 400. Just imagine what will happen. In Calcutta, it's about 600 to 700. That is why COPD is really going up in a very big way. Of course, for management of COPD, what we were doing till now was, first you have to establish the diagnosis, whether it is COPD or asthma, because treatment varies. Of course, most of the COPD people will be smoking. Asthmatics will never smoke because the moment he smokes, he'll get difficulty in breathing. He'll never smoke. Whereas most of the COPD will smoke and get into trouble. The only drug that was used was bronchodilator for chronic bronchitis, an anticholinergic agent to give some symptomatic relief. which we have been using for a long time. Of course, corticosteroids was used because many of the asthmatics will become COPD. So they thought, okay, if there is an allergy component, then you can use corticosteroids. Antibiotics used to be used on and off because there is infection. And mucolytic agent is one of the very good. N-acetylcysteine particularly is one of the wonderful drugs which is used for COPD. Of course, oxygen therapy is the mainstay for COPD when compared to asthma, where oxygen is not a must, but here oxygen is a must. Of course, pulmonary rehabilitation is done only for COPD. COPD is the only thing where we do pulmonary. Now, before we go, we should be worried about, should we really be worried about chronic pulmonary disease in India? Yes, the COPD burden in India has really gone up. 2019 report says the prevalence of COPD has increased from 28 million cases in 1990 to 55 million cases in 2016, which is a phenomenal jump. That's why I said it's become a killer also of late. It's the second leading crossing over the what do you call has changed. Okay, the next one, of course, is COPD alone accounts for over. What has happened? Are you able to see your default speaker? Change speaker headphone.
Sir,
Are you able to hear me? Are you able to hear me?
Yes, sir. Yes, sir. Your voice is clear, sir. Slide is not visible, sir.
Check my audio. It comes. What is your microscope? Failed to do. I'm not audible, is it?
Sir, your voice is clear, sir. Can I audible, sir?
COPD accounts for about 9% of total deaths in this country. Okay. Next, of course, is the status of risk factors for development of COPD are in 2019, the report came as 120 million tobacco smokers are there in India, which is a phenomenal amount. So more than 60% population live in homes where biomass fuel are used. Normally in the world, biomass fuel is not used at all, except here we use a lot of biomass fuel. 56 to 76% of households use mosquito repellent, which is not there in the other part of the world. So that is why this is also there. Then more than 35 million people are chronically exposed to high levels of ambient air pollution, which is occurring because India is a developing country and we have a lot of vehicles coming into the market, and that is why we have this particular problem. Pulmonary tuberculosis and poorly treated asthma are highly prevalent in India, which can also contribute to this. This is why India is a very fertile country for COPD, the huge burden of risk factors associated with COPD. Next, of course, is we have what is the most important thing is a single inhaler may be very convenient and effective because in COPD we used to have, yes.
Sir, sorry for interruption, sir. Your slide is not visible, sir. Once slide is visible, only it will be more interactive, sir.
Slide is not visible, is it? No?
Yes, sir. Yes.
No?
No, sir. It will come like a blur, sir. Sir, can you do one thing, sir? Can you just log out and again log in, sir? For
Yes, I'll stop this. I'll stop this screen sharing.
Yes, sir. Yes, sir. Now your face is
Now
visible, sir.
yeah, but shall I start?
Yes, sir. Yes, sir. Now kindly start presenting slides, sir. We'll check once.
Is it visible now?
Yes, sir. Yes, sir. Now visible, sir. You can play the PPT, sir.
Okay.
So, now visible, sir.
Very good, very good.
Yes, kindly continue, sir. Sorry for interruption, sir.
Oh, no problem, no problem. Now, of course, I told you about this, the burden of this thing. Next, of course, a single inhaler therapy may be more convenient than in any type of airway disorder. A single inhaler is more compliant with the patient. If you give 2 or 3 inhalers, then the patient will not use it properly. So a single drug inhaler will be very effective. And that is why this particular drug which Cipla has bought out is really going to help us. These are the various drugs which are LABA, all these combinations we used to use. But now, of course, the latest drug which has come into the market, which is very, very good for asthma, COPD is. Now, what is the unmet needs in management of COPD is lack of symptom control, because normally people do not get very good symptom control with the treatment of the previous treatment. But it was non-adherence to prescribed therapy because too many drugs were prescribed, so they did not adhere to therapy. Frequent occurrence of exacerbation. Normally, COPD have a lot of exacerbation once or twice a year and get into trouble. So these were the reasons why we were not very happy with the COPD. Of course, now we have a very important thing, inhaled corticosteroid, long-acting beta-2 agonist, a widely prescribed maintenance therapy for management of syrup, which I'm going to tell you about. Once daily regimen. This is the biggest advantage. Normally, you have to give twice daily or you have to give multiple drugs. But here, you have only once daily, initiating once daily FF fluticasone fumarate, and Vilantrol, which is a unique ultra-LABA. This combination has really revolutionized. After this combination has come, I'm able to treat most of the asthmatic COPD people very, very easily. Of course, this drug can be used even for asthma, which I'll tell you how you have to use it in a different combination. Why choose fluticasone fumarate, ICS, and Vilantrol for the management of COPD is because it is a potent anti-inflammatory agent. Fluticasone fumarate is a potent. The best steroid that is available in the market is only fluticasone fumarate. And this also exhibits greater binding affinity to the glucocorticoid receptors and longer retention time in the respiratory tract. That is why this is a unique drug when combined with Vilantrol. Vilantrol is an ultra-LABA, which is highly selective, about 1,000 times greater selectivity to beta-2 adrenoreceptors then beta-1, beta-3 receptors, which other drugs have, produces rapid, within 5 minutes, bronchodilation sustained for 24 hours, which is very, very good. Greater affinity and selectivity to beta-2 receptor than formoterol. Normally, we use formoterol or salmeterol, but this got greater selectivity. Then, of course, greater intrinsic beta-2 agonist activity, faster onset of activity and longer duration of action than salmeterol. And that is why we use Vilantrol now of late instead of formoterol or salmeterol. So both FF and Vilantrol have 24-hour duration of action and suitable for once daily. Normally, when you combine two drugs, both the drugs should have 24 hours duration. Only then it will act very well. So these are the various why we use Vilantrol is rapid onset, no significant effect on QTC interval like other beta-2 agonists, longer duration of action, most potent. Fluticasone fumarate is the most potent ICS, first pass metabolism and negligible oral absorption, prolonged retention, once daily administration. Then approval status for this particular drug globally, yes, this has been approved like Vilantrol and fluticasone. 100 to there are only two types available, 100 to 25 and 225. 125 is used mostly for COPD and 225 micrograms of is used for asthma. Is approved in US, England, Europe, Japan, various countries. 125 once daily is only strength indicated for treatment of COPD. Please remember, whenever you order for this drug, see whether it is 125, which is used only for COPD. Approval status in India, yes, in DPI we have 125 and 225 for asthma. It has been approved. In India, this drug indicated for maintenance of COPD and to reduce exacerbation of COPD in patients with exacerbation history. So this drug has been approved not only in abroad, but also in India, and that is why it's easily available now. Advantage of once daily is once daily ICS, once daily LABA, ultra-LABA with 24 hours duration, provide improvement in efficacy as compared to twice daily. Most of the drugs are ICS or LABA are given twice daily, whereas here it's once daily, aid in improving compliance. I told you compliance is the most important thing for treatment of asthma. If you give any drug once daily, patient is. That is why this combination is very, very useful, covering 24 hours coverage with an OD dosing. Okay, benefits of this drug, evidence from clinical. There are a lot of clinical trials that they have done and found out this drug is excellent for COPD. Now, there is one trial called as Rodrigo study, where they did quite a number of cases, assess the available evidence of the efficacy and safety of this particular drug versus other drugs. And they found out this drug was and the study showed significant increase in FEV1 with FFVN compared to monotherapy. When they give only Vilantrol, it was not very fair. Once they combined with the fluticasone furoate. Then they found there was significant increase in FEV1, forced expiratory volume 1. Okay, significant reduction in the number of subjects with at least one moderate or severe. There were less exacerbations in COPD patients when you use this combination when given separately otherwise. There are other, so in patients with, there was another study called Salford study. This is a very huge study with a lot of patients. In patients with COPD and history of exacerbation, a single dose treatment of these two drugs was associated with the lower rate of exacerbation than the usual care with other medication which are used. So Salford study also showed a similar outcome when they did. There's another study called Submit study, which also said, in fact, this is a huge study with 16,590 patients. That also said, when compared with placebo or all these drugs separately, this particular drug gave fantastic post-bronchodilator. FEV1 was very good when used. And of course, the study was used between 40 and 80 years group, and they found out that this particular drug had a very good outcome. The Submit is the largest survival study, and it shows there's reduction in the risk of mortality, improvement in lung function, reduction in the risk of moderate to severe. In fact, all these were only given by this particular combination of drugs. Of course, there are adherence to this particular therapy is formoterol. When compared with the single drug with the double drug, it was found that people found this particular combination, single dose combination, better when combined with was compared with budesonide and formoterol. Of course, vilanterol safety profile also is very good. In fact, they said this particular glucocorticoid is very, very safe when compared to the other glucocorticoids that raised. In fact, the risk of pneumonia, people were worried about fluticasone having caused it. The risk of pneumonia is significantly lesser with fluticasone furoate when compared to other forms of this thing. Okay, so FF is also a safer compared to fluticasone furoate with respect to pneumonia events. In fact, they say FF is much, much better. Fluticasone furoate is much better. Okay, the summary is, in very severe cases, it was found that 24-hour coverage with OD dosing, better pharmacodynamic and pharmacokinetic profile when compared to other combinations, provide clinical benefits to a large number of COPD patients with the reduced risk of exacerbation, increase in the lung function, improve health-related quality of life, and reduce the risk of mortality. All this happened only with this combination. A greater efficacy benefits and better adherence, which I told you always, adherence with low risk of pneumonia. We were always worried when we use fluticasone about pneumonia. They found out from various studies there is a very low risk of pneumonia, and other CV benefits and better CV safety profile was found with vilanterol. Well-tolerated combination with excellent safety profile. So clinical studies of fluticasone furoate vilanterol combination therapy in asthma. Now we'll come to asthma. Now till now we were discussing only about this combination 125 only for COPD. Now we'll come to asthma, where I told you in asthma, the most important by definition itself is a complex heterogeneous syndrome characterized by airway obstruction, hypersensitivity, and inflammation. So you have these two terms called obstruction and inflammation. For obstruction, you need an ultra-LABA. For inflammation, you need ICS. So that is why we use. So this particular drug was used in asthma also. In fact, the prevalence of asthma is quite high worldwide, about 358 million globally. In India alone, it's quite high. The mortality rate is 0.4 million globally. India contributes to 11% of the global asthma burden, which is very, very high. Globally, 70% of asthma with asthma adherent to ICS-LABA still remain uncontrolled. On an average, Asthmatics India reported 8.4 exacerbations. All this meant that patient adherence to a single drug, and patient adherence is a significant factor for asthma. See, normally in asthma, we give multiple drugs combination twice daily and all that. Whereas after this drug has come, we need only one dosing. So these are the various things. Ultra-LABA is used in this guideline in the last stage in step 4 and step 5. Normally we use ultra-LABA and ICS. So these are the only two medications that are available for asthma: controller medication and reliever medication. Controller medication is to reduce airflow inflammation, that is a steroid. The reliever medication is a beta-2 agonist, like any of the formoterol, salmeterol, and vilanterol, and all these stuff. So they did a study for asthma also for this with this particular drug, and they found out to assess the efficacy of fluticasone furoate with vilanterol combination when compared to the other thing, and they found out that in patients with symptomatic asthma and on maintenance inhalation therapy, initiation of a single dose treatment with this particular combination improved asthma control without increasing the risk of other serious adverse effects when compared to the usual therapy. That was a big thing with Salford. Salford had quite a number of patients in this particular study. Uh, for patients in primary care, and initiating FF and B1 was significantly better than contributing with FF salmeterol. When normal combination, which is normally used, is FB and salmeterol, fluticasone, fluticasone with salmeterol, but they found out this particular combination was much better than using salmeterol combination. When compared with glucosinate formoterol, in the real world study, initiation of once daily with this particular drug, when compared to, they found the use of SABA was very much high when used the other combination. What is SABA? Normally we use ASTHLMA inhaler in between for immediate relief. So people who use the other drugs, they used a lot of SABA, which is salbutamol, on and off. But when they use this particular vilanterol and fluticasone furoate, the use of SABA was much reduced. Okay, that study was important. Now, how do you differentiate between? A lot of people have problems of differentiating COPD and asthma. Normally in COPD, you ask for history, they invariably all of them will be smokers. But asthma, mostly they will not be smokers. They're very unlikely. And normally the age symptoms for particularly an age group is, if you have more than 35, 40 years, then if asthma, symptoms start little early, later in life, then it's very likely to be COPD. But when they start off early in life, it is symptoms start early in life, then it's probably asthma. Here you have productive cough. That is very, very important. When you ask the patient whether he's getting yellow colored sputum, it's very, very common in COPD. Whereas in asthma, they have very dry cough. That is how we differentiate. Breathlessness is persistent and progressive, whereas in asthma, it is intermittent. Whenever he gets an attack only, he has this particular thing. Nighttime awakening, very, very uncommon in COPD, where asthma, he gets up in the middle of the night. Diurnal variation, uncommon, common. Inflammatory cells in COPD is neutrophil predominantly, whereas asthma, it is eosinophil. That is how we differentiate the two. Airflow limitation is not fully reversible, whereas here it's fully. The moment when you do a spirometry, if you give a beta-2 agonist and give a salbutamol and redo the test, the entire the bronchial completely reverses back to normal. That is one thing which confirms asthma. Of course, treatment here in COPD is mostly bronchodilators, vilanterol, whereas here in asthma, because the major cause is inflammation, so we use steroid. These are the difference between COPD and asthma. This I think all of you should know, because in practice, if you do not differentiate COPD and asthma, then you will not know the difference. But fortunately, this particular drug is used in both. So it's very simple. Even if you miss, then you are only thing the dose for asthma is slightly more than COPD. Of course, the most important thing, you must choose a device which is clinically. For this particular drug, you have a dry powder, which is very safe, very easy to use, so you can give it off. Choose a device that is suitable to the patient. Always, when you want to have success in therapy, choose a device that is patient likes. So please treat him now. Give him enough rehearsal so that he is able to do it. Train him. In fact, you should have the time to train people. Check the inhaler therapy regularly. Every time he comes, I always ask them to see. I ask him whether he is doing it properly. I always say the most expensive inhaler is the one wrongly used inhaler. That is the biggest problem for all of us, is we have very little time to teach patients how to use inhalers. That is the problem. If you see this GIF, you find out that lady who told the doctor that she's using inhaler, but see how she's using it, because the doctor did not have time to train. Many of us in our busy practice don't have time. See to it somehow. You When you give an inhaler or give a dry powder, teach them pakka, because the investment in giving a pakka technique gives excellent results. Take-home points are very simple. Despite variability of plethora of drugs and inhalers, control and adherence to asthma and COPD removes poor with clinical. In fact, so many drugs have come for asthma, but still the outcome clinical COPD and asthma has been showing a very bad outcome in clinical as a clinical challenge. Vilantrol and fluticasone are once daily dose, which has really come and is going to change this scenario. Is an effective combination which has been evaluated in several large clinical trials and approved across the world in asthma and COPD. And this particular combination also shown superior in reducing exacerbation, improving disease control, enhancing quality of life with excellent safety profile compared to the other ICS LABA, which has been commonly used. Just as daily brushing is essential to prevent tooth decay, asthmatic or COPD need to use inhalers, either as a dry powder or whatever it is, daily to prevent their airway decay. This is very, very important. This slide normally I put during everything. So thank you very much. I hope I've given you an insight into this particular thing. If anybody has got any doubt about this, maybe I'll be willing to answer. Hello, are you able to hear me?